Brooks, the Global Health Policy Unit at Edinburgh, who's talking about her latest research on COVID-19 and EU health policy. And the floor is yours, Ellie. Thank you.
Thank you, Mary, and thanks for the invitation again to come and speak to the group. That's really lovely. Hi to everyone that's here. I see our friends from the Health Forum at Gastein here as well. That's really nice. I'm going to talk not for too long about COVID-19 and EU health policy. I will try to balance between academic-y theory stuff and some empirical stuff to try and hit all the bases for the people that have joined us. So the work that I'm going to present is sort of combining ideas from two pieces that I've submitted quite recently. So the first is for a contribution to a report called State of the EU in 2022, which is a joint endeavour between the University Association for Contemporary European Studies, UACES, and the UK at a Changing Europe initiative. And that's a report that's due for publication in May. And then the other is an article that we submitted very recently as part of a special issue, and that's co-authored with Anit de Ruyter and Sarah Rosenblum and Scott Greer. So those are the sort of two pieces of work that I'm pulling together from, and thanks are extended to my lovely co-authors for the elements that they have fed in and for working with me on all of this work over the last couple of years now, actually, since COVID became a thing. I'm mostly going to focus on the health union, but I'll explain a bit how I think towards the end that might have some relevance for or put some pressure on various parts of wider EU health policy in the coming months and years. So to get started, to start on a sort of theory point, when we talk in the literature about European health policy, we almost always talk about it using the theory of neofunctionalism. And that's what we have taken forward particularly in the paper for the special issue, is this idea that neofunctionalism is the best place theory to explain health policy because it's the theoretical framework we have for the way that European policy develops that best explains integration in the absence of a comprehensive legal mandate and in the absence of consistent political will. And that fits really nicely with what we've seen in health policy historically. So just to take a step back into neofunctionalism itself, so at a really basic level, the theory of neofunctionalism revolves around this mechanism of spillover. So this idea that if you have integration in one area of policy, if there's one issue or set of issues that member states decide to coordinate on, it will inevitably put pressure for coordination in other areas just due to interdependency of whatever type. And within the literature, we see mostly there are some variations, but most people have settled on these three main types of spillover. So we have functional spillover. That's the very practical logistical situation whereby if you integrate in coal and steel, for instance, you then have to integrate in transport so that those goods can be moved around. It's that very market-driven, necessity-driven, functional form of spillover. The second variant that we read about in the literature is political spillover. So this is where member states, so national governments, officials at whatever level, and it can be at any level, see a value in coordinating at European level and utilize the networks and the mechanisms that they can to push for further integration. So communicable diseases is a really good example here. We see clear value and necessity in working together at a European level so that there is political will to push for spillover and increase that degree of integration and that degree of cooperation. And then finally, we have this idea of cultivated spillover, and that relies much more upon supranational actors. So that might be commission officials or people in the parliament or people in the agencies who see an opportunity perhaps and take on this role of policy entrepreneur to push for more authority or responsibility or role either for themselves or for the Commission or the EU more widely. So there are three within the literature, these three sort of different ways that we think spillover happens, three sort of characteristics of that spillover dynamic. Neofunctionalism is not itself a theory of crisis. Crisis has featured quite heavily within neo-functional frameworks over the years, but it's not designed to explain crisis in that way. This said, the assumptions and the premises of neo-functionalism make it particularly amenable to theorizing crisis and to thinking about what might happen in the aftermath of a crisis, because neo-functionalism relies on this idea of bounded rationality for a start off. So this idea that we never have perfect information. We're always trying to make decisions under time pressure and without knowing everything that we would ideally want to know. That lends itself quite nicely to thinking about what might happen in a crisis situation, for instance. But there are a few neo-functional scholars who've taken this on and tried to think a bit more systematically about how crisis might work within a neofunctional setting. So Philip Schmitter is the main one that we draw on in the paper, and he identifies a series of possible results or outcomes of a crisis scenario. So in addition to spill over, he identifies something called spill around, also this idea of build up, and some other mechanisms, retrenchment, muddling around, spill back, that are more disintegrative, that take us in a backwards direction. I'm not going to explain all of these in great detail because I'll try to give some examples of them as we go through, which I think will make more sense. But just to say that neofunctionalism didn't set out to explain crisis, and in the paper we draw on some of the people that have tried to bring crisis more centrally within the neofunctional model, and then also some of the more recent attempts to marry the different theoretical approaches up. So the failing forward model is a good example here, which combines neofunctionalism with intergovernmentalism and focuses quite specifically on this idea that crisis generates the start of a cycle, and that a series of crises link together to bring about integration in a more or less coherent fashion. So we draw on all those sort of strands of literature to try and put together some analytical framework by which we can think about what's happened in the case of COVID. So health is a really nice illustrative example of neofunctionalism, and the literature is pretty settled in health policy on neofunctionalism as being the best placed framework to explain why we have integration. So its origins in social security are a good starting point. There's a good functional argument to be made there about the necessity of including health within social security frameworks and to facilitate free movement of workers and all these sorts of things. Then when we think about what we call the second phase of health policy, so the phase that's driven by the internal market, the single market, that also has some functional elements to it. And we've seen plenty of examples over the years of cultivated spillover, where it's been officials either within the Commission or the agencies that have utilised opportunities to expand their role and the role of the EU in health. Health's always also a really nice illustration of the role of crisis in integration. The story is quite a well-told one now of how a succession of crises have led to health integration. So starting right back with regulation of pharmaceuticals, resulting from problems with the drug thalidomide, right through to early action on cancer and HIV and illegal drugs being framed as public health emergencies that needed a response and a common response. Mad cow disease was largely a trigger for the creation of the Food Safety Authority. We've seen SARS and H1N1 influenza leading to strengthening of health threats legislation, and even things like the horse meat scandal, which are a bit less well covered, led to legislative change. So health gives us this really nice illustrative example of how crisis can cycle through and lead slowly to a growing and sort of patchwork integrated policy area. In terms of COVID, excuse me, in terms of COVID itself, what can we expect from this case? Well, so the literature gives us some scope conditions about what circumstances we might expect to lead to integration. So in particular from the failing forward model that's emerged more recently, we have a discussion of what kind of crisis is likely to lead to integration. And there are sort of three elements of that. One is that it's encompassing, that it applies to all member states and not just some, that it's unfamiliar, that it's something we don't necessarily immediately know the response, the correct response to, we don't immediately know how to solve, and that it's existential, that it can be posed as a crisis to the EU as a whole and can be presented in that way. And COVID ticks all three of those boxes quite nicely. There are also some scope conditions, particularly in Philip Schmitter's work, around sort of degree of prior integration. So where we already had integration in the area of health threats, that's likely to underpin further integration. Where the Commission already had autonomy in public health and a legal mandate in public health, that's also likely to lead us in the direction of integration. And high interdependency and lock-in, so particularly where we've already got regulatory structures around pharmaceuticals, blood tissue, cells, organs, food safety, all of these regulatory structures that already exist create this set of this dynamic of lock-in, which just means that they're expensive and they're risky to undo and to walk back from. So we're more likely to walk forwards. And interdependency, I think, particularly with communicable diseases, we're living in an example of how interdependent countries are from that point of view. So again, these are all just things that in the paper we discuss how they are likely to lead us in the direction of integration, and then we use the paper to talk about whether that's actually where we're leading or whether we're seeing spill back or roll back in any of these areas. So we focus on the European Health Union, which is a package of measures adopted in November 2020. There is a short discussion, and particularly actually in the other piece that I'm drawing on today, I have a longer discussion of what the Health Union is more widely, but we focus in the paper on the set of proposals that were adopted in November 2020, simply because we want to measure whether we're seeing integration or not. But it's worth noting that the Health Union remains a thing under construction. I think in the UK and a Changing Europe piece, I describe it as a vision, as an umbrella under which new and existing policies are being gathered. And as more building blocks are added, we'll get a better sense of what the Commission wants it to be and sees it being. For now, what we have is this set of proposals that we talk about in the paper, which are very much focused on responding to COVID, on health emergencies and health threats. So we have primarily four and a half proposals that I'll just walk through quickly, and then we have two sort of supporting proposals that we also include in the paper because we think they're important contributors to what the EU is trying to achieve. So we have extended mandates for the ECDC and for the EMA, so the Centre for Disease Prevention and Control and the Medicines Agency. The Medicines Agency one has already been adopted. The ECDC one is expected to be adopted next month. For the ECDC, we're looking at an extension from risk assessment to risk management. That's probably the main takeaway there. So traditionally, the ECDC was responsible for assessing the level of risk, issuing information about the level of risk and communicating that. The proposal would move it to being able to help with risk management, so to make recommendations about which interventions are the appropriate ones and the best ones for member states to adopt, which is a new role. For the ECDC, it will also create a task force so that they can put boots on the ground, as it were, in health emergencies and send health workers or whatever appropriate personnel to the site of an emergency. And they'll be able to make these recommendations on national plans for emergency preparedness and response, which they weren't able to do before. The EMA, by contrast, their mandate extension is restricted very much to emergency situations. So it gives them a number of new roles, particularly over medical devices, which they didn't have before in emergency situations. So this relates to identifying, monitoring and mitigating shortages of medicines and medical devices. So there's expansion in that we're moving from just medicines and pharmaceuticals to include medical devices, and we're moving from just quality and safety and marketing approval and those things to this role about shortages and monitoring shortages. But there's also a very clear line where we're saying that the EMA will have all of these roles and these responsibilities during or relating to health emergencies. It's not in non-emergency scenarios. So there's both some expansion, but also quite a clear delimitation on the EMA case. On the third one, the creation of the HERA, the Health Emergency Preparedness and Response Authority. This was already created in September 2021, and it's supplemented by this Council regulation on medical countermeasures in emergencies. So the HERA, people might have heard of or come across. It's meant to sort of mirror the BARDA, which is the US equivalent agency that essentially centralizes cooperation and coordination of money for research and development in pharmaceuticals and medical devices in biomedicine. And then the council regulation supports that by setting out some of the measures around procurement of vaccines and medicines in emergencies, these sorts of things. So it's essentially bringing a lot of roles that already existed into a much more centralised structure. The budget is higher than it was before, so they've got €6 billion over 6 years. It'll operate in a sort of preparedness and a crisis phase, so it's mostly in its preparedness phase, where it's supporting member states to be ready and making sure that the structures for developing and procuring medicines are in place in advance of the fact, and then it will have this crisis phase where it's launched into response in the event of a public health emergency, like we've seen with COVID. So to some extent, it's bringing together roles that we already had, but it's also adding new roles and a new degree of supranational coordination at the EU level. And then finally, in that list, we've got the revision of the cross-border health threats decision. That's still under negotiation and is the slowest of the ones to be developed. And that's also because it's the most potentially impactful, I think. So the sort of key thing that this introduces is a framework whereby member states will, with assistance from the European level, construct national plans for preparedness and response. So the EU will have a role in sort of auditing these and contributing to them. The ECDC will be able to make recommendations on them. The EU will monitor them as they go through. It also includes some new indicators on health systems and the way in which health systems operate. So this is things like numbers of hospital beds that are available and this sort of stuff, which is interesting because that kind of data is sensitive and it's not at all clear that member states will relish the idea of passing that information up to a European level. In that particular example, so some of the indicators exist in other places and are being brought together, but some will be new. And this act of gathering that kind of sensitive data into one place has historically been a little bit tricky. So it will be interesting to see how that one moves forward. The revision would also give the EU the right or the responsibility, I'm not quite sure what the correct legal framing of that will be, to announce health emergencies, to declare a health emergency in Europe in a similar way that we give the WHO the right to declare public health emergencies of international concern. They're not exactly reciprocal rights as I understand it, but again, it will be interesting because that responsibility comes with a great deal of pressure and a great deal of responsibility and a great deal of critique when those sorts of decisions have been taken. And then there's some additional elements in there about stockpiling and the provisions around procurement of medicines and vaccines in emergencies. So that's the largest and I think probably the most interesting of the proposals that are currently on discussion. In the paper, we also talk about the EU for Health programme and the Union Civil Protection Mechanism. Those both are and aren't part of the Health Union in that these things are all interlinked, but they weren't announced within the same November 2020 package. The Health programme came before, but it's important because it has this enormous budget that feeds into many of the elements of the health union and of the things that are outlined in the November 2020 package. And the civil protection mechanism similarly adopted a little before. It was amended to create rescue, which is the stockpiling sort of arm of the civil protection mechanism, and that was amended again to add medical devices and equipment stockpiles, which didn't exist before. It also gives the EU some powers in procurement and distribution of resources in emergencies, and those are interesting next to the provisions for collective vaccine purchase and things like this that come under the cross-border health threats and indeed the Council regulation for emergency medical countermeasures, because whilst the latter have a higher budget, they're less coordinated, they're more intergovernmental in nature, whereas the purchasing that happens under the Union Civil Protection Mechanism has a smaller budget, but is much more supranational in the governance and the design. So there's a sort of going to be an interesting comparison side by side to see how those things operate together. Essentially, in summary, what we're looking at with the Health Union is pretty unprecedented action in terms of health budget, in terms of legislative action and initiative, which we haven't seen in health for a good few years, in terms of institution creation and strengthening of existing institutions, and in terms of political attention and salience and the place of health on the agenda. And what all of it seeks to do is to address weaknesses that were revealed during the response to COVID, which I'm not going to go into in detail today because we don't really have the time, but all of these things are designed to address weaknesses that were revealed as part of that process. And they reflect, you know, the particularities of EU health policy, of where the sensitivities of national responsibility versus EU responsibility lie. So turning to what we think we found. So in terms of integration and spillover, so prior to November 2020, when these proposals were adopted, we saw some calls for treaty change. We saw calls for treaty change to expand health powers from Angela Merkel, which, if we'd said that in 2019, would have seemed absolutely ludicrous. A budget that was increased by tenfold with the EU for Health programme and the measures to strengthen the civil protection mechanism. So already we were seeing spillover and also the seeds of the political will that would be needed to drive political spillover, even before the sort of the health union itself had been properly fleshed out and announced. In terms of the four elements within the November 2020 package, and we walk through these one by one in the paper and sort of pick apart what's contained within each of the proposals and agreements and what kinds of spillover we think they constitute. So I'll just sort of summarise that here a little bit. So the ECDC, we think what we see there is mostly cultivated. It's very difficult because these types of spillover, inevitably there are grey areas and fuzzy lines between them, but there's certainly been an extent to which the ECDC and the EMA proposals institutionalized roles that these agencies took on out of necessity during the pandemic. So we draw on other excellent research by colleagues like Thibaut de Roule and Isabelle Angeli on how, particularly with the ECDC, these roles were being done during the pandemic because they had to be, and the proposals that have been put forward since are putting in place an institutionalization of those roles so that those roles will continue and become part of the formal mandate. That, for us, is at least leaning towards cultivated spillover, is this idea that supranational actors are using the opportunity they have, given that they were forced into taking on these roles, to say, hey, look, this has worked quite well, actually, and this is what we needed to do in this scenario, so our mandate should reflect that there was a necessity for us to do this. So that includes the new tasks that the ECDC has around risk management, the bodies like the task force that have been created, which gives it new resource, and its authority to make recommendations on national plans. All of those things expand the scope and also assign new authority at the supranational level, which makes it spill over. In the EMA, we have some spill around. So we definitely have new tasks. The EMA has been given new things to do that it didn't do before. It didn't cover medicine shortages before. It didn't deal with medical devices before. In fact, that proposal was made in 2017 when they were working on the new medical devices regulation, but was rejected for political reasons. So it's interesting that the crisis has proven enough to give the EMA a role in medical devices where that wasn't deemed politically feasible in the past. But those new tasks are predominantly governed in a more intergovernmental, certainly more intergovernmentally than the ECDC's frameworks are looking at the moment. So we think what we're seeing there is a bit more spill around than spill over. We get build up where we build up the supranational institutions, but we don't necessarily stretch their mandates too much. And where the ECDC is being given more resources and more capacity to do the things that it was already doing, what we're seeing there is build up rather than spill around. It's the difference between the two things. What we're not quite seeing is spillover. It's not quite that all-encompassing an increase in task and mandate and an increase in authority. So that's kind of a horizontal and a vertical movement to see full spillover. And we argue that because of this delimitation to emergencies only. We argue in the paper that because this hasn't been as encompassing as it has been for the ECDC, that's maybe not quite the kind of spillover that we've seen for ECDC. With the HERA, again, we're talking about build up because there's lots of centralisation, but there's not a whole lot of new stuff. A lot of it's bringing existing things into a more centralised structure and therefore increasing the degree of coordination and the capacity and the role of the EU, but without stretching the mandate or increasing the mandate particularly wide. And then there's some spill around, and there's spill around because the role of the crisis board is quite strong within the HERA setup, which is a slightly more intergovernmental structure where the member state role is a little bit stronger. Similarly, in the health threats decision, the HSC, the Health Security Committee, that's become very central. So again, that has a bit more of a spill around nature to it. We're arguing a little bit for political spillover. Again, these definitions overlap hugely, but the extent to which member states are deferring tasks and responsibilities upon the Commission that we would not have expected them to defer upon them a couple of years ago suggests political spillover, we argue in the paper, and we trace that back to some of the things that we saw pre-EHU and the enthusiasm of national governments for giving the EU more powers in these areas around declaring public health emergencies and taking a role in national planning, because we can see national governments and national officials being enthusiastic about that and seeing the necessity of that for us speaks more to this idea of political spillover. So in conclusion, and what we wrap up with in the paper is to say, well, look, there's definitely political spillover, and to some extent this is a weakness of or a reality of the neo-functional model, which is that nothing can happen unless you have member state support for it, such as the nature of the EU process. Therefore, everything is political spillover. But I think we have to be a bit more nuanced than that. So what we argue and conclude in the paper is that, well, look, here's where the political spillover started. There have been some limits. We obviously didn't get treaty change. And obviously, as time passes, interests change and preferences change. And member states maybe wouldn't support that anymore now that they see these alternative options, and these alternative options are moving forward. But we trace the political spillover through, and we acknowledge that that there is a lot of spill around, that a lot of the mechanisms, particularly things like the Health Security Committee and the Crisis Board, are quite intergovernmental in nature. They have a big role for member states. It's not that all of these responsibilities have been handed off to the Commission and the agencies of the sort of a great, you deal with this and this won't be a national responsibility anymore. That's clearly not the case. So we account for, in our conclusion, the political spillover and the degree of intergovernmentalism. But we also have quite a long discussion about the foundations for cultivated spillover. And that's largely based around the health threats decision, but also the other 3 decisions, and in particular the EU for Health programme. So where we see this much bigger budget and where we see the increase of health on the EU agenda and the salience attached to it and the people talking about it and attending to it in a way that the EU health policy wasn't attended to before, we argue that this is laying the foundation for something beyond emergencies, beyond COVID, beyond what's outlined in the packages that were published in November 2020. So some of that is linked to things like the indicators on health systems, which could be used for any number of things once they're in place. The EU for Health programme is not just about COVID and emergencies, it's about all of the EU's other health objectives and pre-existing health objectives. It's about the Europe's Beating Cancer Plan, it's about the Farm to Fork strategy, it's about all of the much more forward-looking and much more progressive-looking policies on things like the labelling of alcohol that we're seeing come out of the Beating Cancer Plan, and we're seeing supported by the budget within EU for Health. There are now a number of avenues where entrepreneurial and forward-looking members of the health community, and particularly within the Commission, could push and could put this cultivated spillover into action using what's been put in place here. So we end on this note where we say, well, look, this is obviously not a case where we've had a crisis and we've simply handed all responsibility over to the EU, but we also don't really want that, because that would be limited very much to a health emergency scenario, because that's how we would be responding to COVID. What we have instead is a situation where we're putting a bit more of a holistic foundation in place, covering all aspects of health and not just health threats and emergencies, and leaving that there so that some of the dynamics that we've seen in the past, where individuals are able to act as policy entrepreneurs and push individual elements forward, those could then be used in areas far beyond health emergencies to tackle health inequalities and the differences between health systems and the wider sort of social determinants of health in that more holistic way. And I think that might be, yes, where I'm up to. So thanks, Mary. I'll leave that and hope that there are questions, comments, and thank everybody for listening.
Okay. Thanks, Ellie. I'll just stop recording.